after that, we can prepare our patient and do it as an elective surgery, which has the advantage of doing it in one stage. We did it a few days later, elective sigmoid colectomy with primary anastomosis and the patient is fine. Cecal volvulus, another event which happens in the cecum. It's uncommonly seen, in fact, but also present with the same picture of sudden dilatation with the risk of strangulation and ischemia. Pain in the right iliac fossa with quickly developing abdominal distension. Plain X-ray will show the hugely dilated cecum. This is example of the cecal volvulus on X-ray and on operation. Small intestine volvulus usually a result of some attachment to the wall of the small bowel at the loop, which around it the small bowel loop will rotate. Sometimes it's a tumor, sometimes fibrous remnant of the tenointestinal duct, as in Mickel's diverticulum. The clinical picture is a picture of intestinal obstruction. On operation, untwisting, if the bowel is healthy, we just resect the pathology which caused this twisting. If it is gangrenous, it should be resected and anastomosed. This is small bowel volvulus. Neonatal intestinal obstruction. In fact, since you have pediatric surgery lectures now by Dr. Kirani, I will not go through this pathology in detail. We have atresia, which is failure to develop parts of the small bowel, partly or completely, which has different types. Volvulus neonatorum, volvulus in the neonates. There is what is called Ladd's band, which around which the volvulus will happen. So in laboratory, we detwist and then remove and cut this band. Meconium ileus, it's part of the systemic disease mucoscosis, cystic fibrosis, which will affect the secretions of the bowel and the secretions of the airways. And usually the prognosis depends on the situation of the lung. Sometimes treated with meconium ileus, sometimes it's treated with gasographene enema, which will try dissolving the inspissated meconium and relieve the obstruction. Necrotizing enterocolitis seen in premature patients results in ischemia, and the child is very toxic, and the mortality is high. Hair-borne disease is an important disease to know. It results from a ganglionic segment in the distal large bowel. The absence of the ganglion cells, the plexus of Auerbach, which is the mesenteric plexus of the colon. This will result in failure of relaxation of this segment, and it will be almost obstructed. The distance of the aganglionic segment varies from case to another, and it will make the presentation early or late. So it presents with complete constipation, failure to pass meconium, and severe constipation. On abdominal X-rays, it showed dilated loops of colon except the distal one. And on contrast study, it will show the stenotic distal part with dilation of the proximal part. Rectal biopsy will establish the diagnosis by complete absence of ganglion cells. There are cases described as acquired megacolon, sometimes mixed Hirschsprung disease, but it's a severe constipation rather than pathological aganglionic segment. Usually it shows impacted feces in the rectum. Biopsy of the rectal wall will rule out the diagnosis of Hirschsprung disease. The treatment, usually the elective surgery is delayed after 6 months old, between the 6 and 9 months old. Unless there is complete obstruction, then colostomy should be done immediately. So they do colostomy in the early neonatal period, and after the age of 6 months, the elective surgery is done. Usually by resecting the aganglionic segment and abdominal perineal pull-through anastomosis between the normal part of the colon and the anal canal. During operation, we should take further section from the parts we think it is completely healthy to make sure it is healthy for doing the anastomosis. In rectal atresia and imperforate anus, also I will leave it to pediatric surgery, but usually the quick assessment of this imperforate anus done after delivery of the baby, when we see that there is a septum and there is complete absence of the anus, then we put a coin in the anal cleft and take an X-ray, and we see the distance between the coin and the air bubble in the distal healthy rectum. If it is very short, less than 1 centimeter, it can be opened and sutured all around. If it is long, then it will be treated on stages. Intussusception is collapse of one portion of the intestine into the lumen of the immediately following bowel. It's called intussusceptum. There are types of intussusception, the most common of which is ileocolic. Ileocolic, when the ileum intussuscepts through the ileocecal valve into the colon, which makes 75% of these cases. Most of these cases are seen in infants and young children. In adults, it sometimes can be caused by a pathology which is making an apex for intussusception, like a small polyp or tumor. The problem that this intussusception will result in strangulation, in cut of the blood supply, and end with gangrene if not treated. Picture of intestinal obstruction in a child should draw your attention to intussusception, because commonly seen in children. The non-operative treatment is by doing a barium enema. The contrast will push the intussuscepting part, hopefully to reduce it completely. If not successful, then we have to go to operative treatment. In operative treatment, we explore the abdomen, we go to the intussusception part, and then try to push the apex of intussusception through the bowel until you move it out. Don't pull. Pulling is dangerous because it ends with perforation. So pushing the intussuscepting part outside until you completely reduce it. If there is already established gangrene, then it should be resected and anastomosis. paralytic ileus is very important to diagnose post-operatively. Any laparotomy will end with paralytic ileus. This paralytic ileus should recover in 24 to 48 hours maximum. If it is not, then don't assume that it is paralytic ileus, but look for other problems. Consider leaking. If you have anastomosis, consider anastomotic leak. Susan. So paralytic ileus is an obstruction, but due to paralysis rather than mechanical obstruction. It presents with abdominal distension, absolute constipation, and sometimes vomiting, with no bowel activity, no bowel sounds, and no pain. Because there is no peristalsis and no bowel sounds, there is no pain also, no colicky abdominal pain. Usually the pain is from exaggerated peristalsis. Peritonitis will cause paralytic ileus. In advanced case of stomach obstruction, if there is perforation, there is complications, strangulation, this will end with peritonitis, and the peritonitis will cause paralytic ileus. Sometimes it's precipitated by metabolic causes, the most important of which is hypokalemia. This is why your post-operative patient should be followed very closely for his potassium levels to correct his hypokalemia, so that you will not add to his already paralytic ileus. Some drugs can precipitate this. So you observe the patient, you give him enough fluid, you correct his hypokalemia, and you wait, maximum 48 hours. After 48 hours, we should be looking for a cause of this prolonged ileus. We can do, for example, CT scan with oral contrast to see if there is any leak. And we treat on the same principles of stomach obstruction. We keep him PO, we decompress him with NG2, we give him enough IV fluid and electrolyte replacement. CT will give you an answer if there is another pathology adding to his paralytic ileus. So the same conservative treatment. If it is prolonged and we already investigated him with CT scan or so, and we make sure that there is no pathology going in and it is just prolonged paralytic ileus, sometimes there is it is with pharmacological treatment, giving some medications to try to stimulate the bowel activity, like metoclopramide, placebo, which will help in emptying of the stomach and bowel, and erythromycin also, which is stimulates the motility of the bowel. That's it for now. Any question?